Yeah. So Merle will be talking on common presentations of uncommon organism.
Okay, so while it's connect, right. So good morning, everybody. I'd like to thank the AIOS, the APOC, and greetings to all the dignitaries on the dais. And it's great to be back in Vizag. So I'm going to talk on common presentations of uncommon organisms. I don't have any financial disclosures. So this is about, I'll take you through a couple of cases which will help you understand about the presentation. So this is about a 33-year-old lady who is a farm worker, and she presented to us with this kind of picture where you notice that she has got an infiltrate which has got multiple patchy infiltrates if you see here. But when you look a little closely, you realize that some of these, and we don't have the slit, shows you some pinpoint infiltrates. When we scrape this, this is a very classical picture of very fine, slender, beaded bacilli which have got right angle branching, which is very suggestive of nocardia. And nocardic keratitis is a rare infection, comprising only about up to 8% of the cases, but its typical picture is this wreath-like pattern that you see. And if you come across this, this is a definite no-brainer for nocardic keratitis. Predisposed by trauma with soil, and it usually gets, usually manage it with topical amikacin 45, 2.5%. So the fluoroquinolones also do well, and if you have access to IVCM, then that's something that can help you diagnose it. Now, another uncommon organism is something like this, which presents to you with these, SPKs which look like they're stuck onto the cornea. When you do a slit, you realize that they're restricted to the cornea and there's nothing happening in the anterior segment, in the anterior stroma. The eyes are very minimally congested. Patients are not all that symptomatic. And you would notice that they have a follicular reaction, usually occurs in only one eye. There may be some prior history of getting wet in the rain. And if you happen to scrape these, you get this very beautiful picture of a starry sky appearance on fluorescein with the calcofluor white. And when you do a gram stain, you notice that there are these oval spores which take up this polar staining. So this is a classical microsporidial conjunctivitis, and it also causes keratitis, can also cause scleritis, can also cause endophthalmitis. But the predisposing factors, it used to be bilateral disease in immunocompromised individuals, but we're seeing a lot of unilateral cases in the monsoons. Can happen with CL wearers, can happen with prior topical steroids, or exposure to contaminated water. The other form of the same disease when it affects a stroma is when you have this mid-stromal infiltrate which has got a granular kind of appearance, and if you make a slit and higher magnification, you can actually visualize the granularity. So these cases of microsporidial stromal keratitis, they have a prolonged history, months to years, with a waxing appearance. The diagnosis is delayed because we often misdiagnose it as HSV, and they don't respond to steroids, or they show initial response and then they worsen. So the predisposing factor here again is trauma or contaminated water, could be due to contact with some animals. And if you have access to IVCM, you can appreciate these hyperreflective dots in the stroma. So this is a tool that not everybody has. Often we have to do a biopsy to diagnose it, and you can appreciate on the acid-fast stain as well as on the gram stain these little oval-shaped bodies which are present, and they've got a polar staining that's typical of microsporidia. Treatment, topically, fumagillin can be used, but it's not available in India, so we'll end up doing a PK. Now, this was a patient who presented to us. He's a 40-year-old gentleman with a very long history, almost 3 months duration, on natamycin, milfloxacin, and he was using both these hourly, but there was no response. So when he presented, he had this kind of an irregular epithelium, some cellularity in the stroma. So somebody misdiagnosed him for herpes and put him on topical steroids and antivirals, came back a week later with this picture. So obviously when you see this ring, now this is a dead giveaway. This is obviously going to be acanthamoeba if you scrape it, and we picked up these double wall cysts on the gram stain and put the patient on 0.02% PHMA and chlorhexidine, but didn't do well because obviously he was on steroids. But ultimately it came under control. And when you realize acanthamoeba is also one of the uncommon organisms in the West associated with contact lens wear, but not so much here. It's a protozoa, and it usually causes unilateral infection, tends to penetrate in through the intact epithelium but doesn't go beyond the Descemet's membrane. And the predisposing factors, like I mentioned, in the West, it is definitely contact lens wear, but here it's trauma, so occurs more in agricultural workers exposed to contaminated water or soil and in warmer climates. And also there's an effect with the socioeconomic condition as well. There have been episodes also occurring after surgery, like post-RK, PRK, or laser refractive surgery. So characteristically, there'll be symptoms out of proportion to signs. They have an epithelopathy. You see these SPKs and pseudodendrites. About 60-something% have got radial keratoneuritis, where you have inflammation along the nerves, and you can see that in this picture here. And they tend to have a ring infiltrate. So the Gram stain and the QH stain will help you pick it up, and it grows in NNA with E. coli overlay, because these trophocytes will start eating up the E. coli. We can also use PCR to diagnose it in difficult cases, and IVCM, like I mentioned earlier. So now another case that we came across was this patient was initially treated with steroids and antivirals. He showed some response and then he worsened. When we scraped it, we got atypical mycobacterium, and you can appreciate these very slender bacilli which take up 20% stain with acid fast staining. So this responded very well to the amikacin. And sometimes it could have a waxing and waning course, so sometimes you may have to add a second drug, which is usually a fluoroquinolone based on the sensitivity. So this is how he presented, because he required a second drug, and that was what added subsequently. But then atypical mycobacterium per se tends to occur following trauma, usually with a corneal foreign body which may have been removed initially, can also occur following refractive surgery, and can be worsened or aggravated by the use of topical steroids. The classical clinical picture is a multifocal infiltrate. As you can see here, these multiple loculi could have satellite lesions as well, could also have a cracked windshield appearance, which is something that we have to look for, and could also present as infectious crystalline keratopathy, so we have to keep that in mind. But it also is particularly famous for having a waxing and waning kind of a course, because of the fact that it gets mistaken with HSV. I mentioned the 20% acid fast stain that can be used to diagnose it, and the cultures, but it takes a long time to grow, so you have to keep that in mind as well. Now this patient was mistaken for fungus. It presented with this classical picture like a hyphate edge, was put on natamycin hourly, and showed initial response, and then suddenly started worsening. So we reviewed, we rescraped the patient. When we rescraped and looked at the slides, you see these very fine aseptate filaments. They've got this ribbon-like folding, which is actually pythium. Went back and looked at the clinical picture. Pythium actually has got these dot and tentacles in the stroma, which you have to watch for, and has this guttering. So that's something that we have to remember. This is not actually a fungus, it's a pneumycetes, but it responds well to linezolid and azithromycin. We can use both of them topically, along with either oral or linezolid or azithromycin. And I'm not going to go through the details of this for the lack of time. But the last organism I have is this particular patient who had HZO. She presented us with this kind of a PD type of picture, but you notice there are some infiltrates here. So we scraped this and we got this. So this is yeast, candida, which tends to occur in immunocompromised individuals. This has got this typical picture of this dimorphism that's setting in there. We put the patient on fluconazole, added a tarsorrhaphy, and over time this patient gradually healed. So in summary, the eye sees what the mind knows, and therefore it's important to know about all these organisms, what is the clinical picture, because only if you know about them, you can actually try and think about the possible diagnosis and get a microbiological workup done. If you diagnose it early, there could be good recovery with medical management. Thank you very much.
Thank you, Dr. Marl, and a nice pictorial and nice tips about the diagnosis. Now, Dr. Bhanati is here? No, she is not here. So I'll be Prafulla speaking last. Madhu Daraju is there? No. All are absent. So I think Amit is here. So Amit, please. So all you want to know about femtosecond laser assisted corneal transplants. We'll take question after this. So that after that, we'll take question.
So in the meanwhile, while he's connecting, are there any questions on the previous talk related to uncommon organisms? How many of you have seen Pythium? Hands up. How many of you are awake?
Shall I
Okay.
start, sir?
Yes, yes. Please carry on.
Well, thank you, sir, and I would like to thank the AIOS for this opportunity. And essentially, I'll be talking about femtosecond laser-assisted keratoplasty and try to remove some of the myths around it. So we know that femtosecond lasers, we are used to seeing them, getting people getting LASIK done or for intacs. But there is another very useful way in which the femtosecond lasers can be used, and this is to perform the keratoplasty. So basically, we have three cuts at our disposal. One is called the posterior side cut, one is the ring lamellar cut, and the third is the anterior side cut. And once we stack these three cuts together, we can use that to create various patterns. For example, this is the very popular top hat configuration, or we can use it to form a Christmas tree configuration, or there's another configuration known as tongue in groove configuration, or which is my favorite, is the mushroom shaped configuration, right? So what are the advantages? Why do we want to make these shapes? One, that the femtosecond laser gives a very precise cut, and there is no other means by which we can actually shape the cornea like a mushroom. So this leads to a very smooth graft host transition, also along with an improved wound tensile strength, and also it is possible for us to remove the sutures very early. Now this is what the machine looks like. Basically, we have to be very careful while we are entering data at what depths we want the cuts and what is the size of the cuts. So there is a space for ring lamellar cut and posterior side cut and anterior side cut. You have to feed the parameters. In this case, this is an indigenous artificial anterior chamber. Nowadays, I use Moria's artificial chamber also. And what happens basically is you applanate the cornea after fitting it on the artificial anterior chamber, and you can see by the generation of bubbles that the cut starts from the posterior side and then it proceeds to the anterior side. So the cut is starting here. We can see the ring lamellar cut is happening from outside to in. Posterior side cut has already taken place. Now the depth of this cut is usually between 50 to 70% of the corneal depth. This depends on the surgeon preference, what is happening. And this is then followed by the anterior side cut. So in this case, I am performing a mushroom shaped graft in a patient of keratoconus. So after marking the center of the cornea in the recipient eye, we have to applanate. The patient is of course blocked because it's not possible to block the patient after this is done. So again, we can see this generation of bubbles because this cut starts at a level of beyond the maximum pachymetry of the cornea. And this is followed by the ring lamellar cut, and this is then followed by the anterior side cut. So these parameters, disparity, some people keep a 0.25 disparity. This was a patient of keratoconus, and the parameters remained the same in the donor and the recipient graft. Now what happens is that we very gently, using a Sinskey hook or some kind of a blunt instrument, we have to just kind of separate out the tissue. It doesn't require much force, and we should not actually overuse the force, because if you overuse it, you will create a kind of a lamellar pocket into the donor lenticule. This is not desirable. Sometimes just few strands are left and we can just cut them with the scissors instead of trying to pull too much on them. Now when we come to the recipient eye, it's just like sometimes possible just to strip it off. It depends on what energy you have used, and pupil should be pilocarbonised just to avoid any damage to the lenticular surface. And viscoelastic is being used, and then suturing is carried out. Now, if you see the sutures, we say 90% depth, but not so in femtosecond keratoplasty. So it has to be with around the ring lamellar cut that we suture, and the surgery is completed. So we see, so there are certain issues with penetrating keratoplasty where FLAC overscores, because we need, there's an anterior-posterior and a rotational misalignment of the tissue. There's excess and uneven suture tension. There's a weak cornea. There's a slow and asymmetric wound healing, and there's a need for tight sutures. And all of this, they bring down actually the quality of outcomes that we want in these patients. On the other hand, with the femtosecond laser, very precise cut, and it's a customized cut. We have a greater accuracy of wound construction. We can plan multiplanar incisions, and tight sutures are not required. And what I've seen is we can go in for a fairly early suture removal, because this is a fibrosis along the edge. The cornea is much more thicker. My experience I wanted to share, especially in patients with thin and ectatic corneas, where all these issues are more magnified, and especially the issue of high post PK astigmatism, and we have to apply tight sutures. Sometimes there's a leakage from the sutures. In this case, the central pachymetry was 247 microns, and it's a very thin ectatic cornea. Patient was contact lens intolerant, and when we performed this surgery, and the post-operative refraction was -3.5 with -1.5 cylinder, and the difference of keratometry pre-operative versus post-operative was to the tune of 20 diopters. And if we see this, see how beautifully the graft and host junction is opposed, and not only the anterior surface but also the posterior surface of the graft is very well opposed. And the pentacam also showed that the visual results were very good in this patient. Similarly, a post hydrops eye, we can see the scar of the hydrops also, again 76 micron cornea, and we can see that post-operatively the patient is just having -3 with -3.5 cylinder, and if the pachymetry allows, we can even polish it and improve the vision using a topo-guided PRK or something like that. Similarly, a 127 micron cornea, very, very thin cornea. So these are so challenging when it comes to doing a routine OPK, but because we are giving that little collar around the graft, it significantly strengthens the cornea and gives great visual results in these patients, not only the anterior but the posterior surface. And in this case also, the improvement in keratometry was 23 diopters, and sutures could be removed as early as 5 months in these patients. We can also use it to perform lamellar keratoplasty in these patients, and the CDK or other indications, the patients do fairly well in these scenarios. So what I've shown is that FLAC offers very distinct advantages, but it is not meant for all conditions. Wherever the cornea is hazy to edematous, where it might not penetrate, then FLACS is probably not the way out, and we have to resort to the routine keratoplasty. Thank you very much.
Thank you, Amit. Lovely presentation and nice animation to understand the flags. So we'll take question after Dr. Sudhakar will be speaking on post-operative dry eye management. Then we will take some questions.
Right.
We'll take question by this time someone comes, then we'll go.
Good morning. Yeah. I must thank the AIOS and the APOS for giving me this opportunity. Today we are talking about post-operative dry eyes and how to manage them. This is essentially a cornea session. So refractive surgery is a great stride. LASIK is the most common refractive surgery that is performed, and the advancements have ensured that the complication rate is less than 0.5%. But minor complications like dry eye are very common. And even though they may be classified as minor, dry eyes can substantially affect patients' perception of their surgery and their level of satisfaction. So if you see, it is inevitable, it is a neurotrophic state because you're cutting the sections of the cornea and the corneal nerves. But the issue is that though we think that about 6 months down the line they are okay, but 20 to 40% of the patients still persist with dry eye symptoms even after 6 months after surgery. So why is this? So they may not actually present with dry eye. They can come by with foreign body sensation, burning, pain, itching, photophobia, or blurred vision. So the surgery itself was done for clear vision. So if they're going to report blurred vision, obviously they're going to be very unhappy about it. So what are the risk factors for excessive or dry eye beyond the usual 6 months? The most significant risk factor is pre-existing dry eye, which probably we have missed, or a borderline dry eye which has aggravated after surgery. Long-term history of wearing contact lenses before LASIK for the same visual problem of myopia would be an adding factor. So any contact lens patient, despite you discontinuing the lens for 2 weeks or so for the stabilization of the keratometric readings, should also be thoroughly evaluated for dry eye. Asian races have a higher prevalence of post-LASIK dry eye. And there is a small military study, genetic influence of polymorphism in the thrombospondin 1 gene, but this has yet not come into clinical relevance in India or abroad also. So what are the other surgical risk factors? A smaller hinge, which means you've taken a larger cut, is a risk factor. Sectioning of both the temporal and the nasal fibers for a superior hinge can cause more dry eye. A larger flap diameter and a greater ablation can also cause more dry eye. Other risk factors include the female population, smoking, low corneal sensitivity, and the coexistence of seborrheic blepharitis or meibomitis, and the commercial or the environmental factors, and the use of computers or screens for more than 4 hours a day. So this today with the digital world, I think almost every patient need not be a software engineer to spend 4 hours on the screen. Doctors, housewives, businessmen, everyone spends more than 4 hours on their screen majority of the time. So it is essential for you to counsel at the preoperative level itself that your screen use may prolong your dry eye conditions for more than beyond 6 months. So today most of the time when I am advising or counseling LASIK, I say you may have to use drops for close to 1 year after surgery. So the ocular surface of LASIK and dry eye. So evaporative dry eye due to MGD is the most common reason for the dry eye post LASIK. Inadequate tear film integrity and the function plays important role in the evaporative dry eye. And the neurotrophic nature, because these corneal nerves are sectioned, compromises the lacrimal function unit, at least transiently. So what are the pathological mechanisms involved in this? That will be the impact on nerves, which will impact on the sensitivity. The goblet cells, because again, the nerves actually are cut at the corneal level, but somehow even the goblet cells come down significantly in the conjunctiva, though we are still not fully understood why they do. There's an impact on the epithelium, both the regeneration, the regularity of the epithelial hypertrophy, and that it influences the T-but. The tear concentration is the final end result of all the pathologic mechanism causing increased in osmolality, and the tear film dynamics, which is the fluorescent T-but. So this would be the overview to the pathology. So LASIK would cause sectioning of the nerves, would cause decreased corneal sensitivity, would then cause decrease in blink rates. If the blink rate is decreased, your meibomian gland, every blink releases some certain amount of meibum into the tear film, which is stabilize the tear film. So that is decreased. The blink rate also causes increased evaporation. The sectioning of the corneal nerves, because of the lacrimal functional unit going down, causes decrease in tear secretions. The damage to the goblet cells will cause decrease in mucin, and therefore the tear film does not adhere to the corneal epithelium. And the altered shape, because of your LASIK, alters the tear film dynamics and the tear film breakup time too. So ultimately it results in ocular surface damage and the dry eye symptoms. This study shows the nerve sensitivity, because you've sectioned the nerves, and takes almost close to 6 months for the nerve sensitivity to come back not to normal. So there is a documented reduction in goblet cell sensitivity in the conjunctiva, which will cause, as I said, decreased adherence to the tear film. Besides that, the quality of tears also change. The tear calcitonin gene-related peptide increases. The increase in inflammatory mediators such as matrix metalloproteinase and the epidermal growth factor are also seen when you chemically analyze the tears post-LASIK. So if you take 0 as the baseline, the tear film parameters, Schirmer's and T-but come down, and change in tears osmolarity goes up, increasing of the tear film. The impact of LASIK on the ocular surface is that there is irregular astigmatism, which can be caused because of T-but and decreased T-but and superficial punctate keratitis. If this is not addressed, this causes long-term refractive regression because of epithelial hyperplasia. So the very fact that you are doing a surgery to correct refractive error, you are again inducing regression by not treating the dry eye. And if you see that more than 50% of the patients who are dissatisfied with LASIK can be directly attributable to dry eye. So how do you optimize the ocular surface before and after the? So before, it is essential to do a complete and thorough evaluation of Schirmer's test, TBAT, myomography which required, staining and OSDI, and especially contact lens wearers to diagnose whether they have a pre-existing dry eye. Mild and moderate dry eyes can be optimized, whereas severe and neuropathic dry eye, you have to rethink whether you want to do this surgery at all in the first place. So preoperative and postoperative, there is nothing new. It's just that you have to identify these cases preoperatively itself. So aqueous deficiency, you treat with lubricants, you can treat with cyclosporins and essential fatty acid supplements. But if there is a patient who is going to require punctal occlusion, systemic treatments or oral picoalquins for very dry eye, again you have to reconsider your decision for taking up this patient for refractive surgery. In evaporative dry eye, the standard treatments of azithromycin, oral doxycycline and tears would do. But if there is a patient with severe dry eye, with severe myomitis, it may be worthwhile to send him for a thermal pulse or a pulse myomitis treatment, because this will give him relief for close to up to 1 year after surgery. So your dry eye also is going to be there because of the surgery induced dry eye. So it is good if you can do that. Okay. Neuropathic pain is typically, most of the time it comes post laser. So we do not, very difficult to identify pre-LASIK. So post LASIK, if somebody comes with severe pain, continuous pain, not getting relief to any of the tears molecules, and all your evaluation of TBAT, Schirmer's and all appear to be normal, a drop of Parkin test was and that causes a relief in these neuropathic patients, and these patients would require consultation with some neurologist, some antidepressants, typically seen in female patients post LASIK, but also very rarely a high-strung male patient also. They may need requirement of vitamin D or carbamazepine. So this is after you have evaluated your dry eye completely, both pre-op and post-op, and you see that there is no component of dry eye, is almost a diagnosis of exclusion. And of course, over-treatment without coming to a good diagnosis can always cause toxic dry eye. So ocular surface post-management of cataract surgery. If you see the cataract surgery, it is sheer volume. The number of patients who come with dry eye may be very less, but because you are sectioning, you are doing 27 million surgeries in 3 years, and in these patients, you are going to section the corneal nerves, either the scleral part or the corneal part, and majority of the surgeries done in India are SICS. So you are looking at 27 million patients and subjecting them to potentially the partial neurotrophic effect.
Summarize this part?
Yes, this is the last slide. Okay. So the role of hyaluronic acid-based artificial tears. So the long-lasting matrix of the HP guar and shields the eye. It provides advanced hydration and protection, allowing damaged cells on the ocular surface to heal, and acts as a bandage lens almost to allow the healing of damaged epithelial cells on the ocular surface and promotes corneal epithelialization. So the conclusion is post-LASIK dry eye is common. Some patients may experience it for prolonged periods of time. It is important reason for morbidity and poor patient satisfaction. Dry eye could present before LASIK and may worsen post-LASIK. Diagnosis and management of pre and post-LASIK dry eye is beneficial to improve the outcomes, and hyaluronic acid artificial tears not only improve symptoms but also improve ocular surface parameters that are beneficial to pre and post-LASIK dry eyes. Thank you.
Dr. Rajesh Sinha is not here. Bhanati, Praful Maharana, and also Modhu Uddaraji, I think he is in court martial. Who is there? Praful Maharana is here. Please. His talk on DSAK in the era of DMEC.
Are there any questions in the meanwhile from the audience about dry eye or anything? If there aren't any.
The incidence of dry eye is same post-LASIK and post-PRK. Is there any difference?
So you cut the nerve bundles on both sides in LASIK, and so therefore the dry is supposed to be more in post-LASIK as opposed to PRK.
So good morning. First of all, thank you AIS for this opportunity. And sorry sir, Dr. Basak pointed out last time when I was presenting that it's not the era of DMAC. So little correction, DSEC and significance over DMAC. That is what I am going to discuss. So nowadays, this DMAC is the craze. Wherever you go, people talk about DMAC only. But you have to remember, other than DMAC, there is a procedure called DSEK or DSAEK, which has certain advantage over DMAC. And in the Indian scenario, when you are working in a referral center, you may be you may get cases more who need DSEC rather than DMAC. So this talk is about that only. So when it comes to DSEC versus DMAC, DMAC has all the advantage when it comes to visual acuity. The percentage of cases that achieve 6.6, the time to rehabilitate such patients, the quality of vision, contrast sensitivity, all things are better with DMAC. However, with DSEC there are certain advantages, not in experienced hands maybe, okay, but somebody who has done maybe 50 to 100 DMAC, so these points are valid for those surgeons. Learning curve is definitely easy with DSAEK or DSEC. Why? Because you need not to, the donor preparation is quite easy and it's a thick graft. The graft attachment is quite easy. In DSEC, it's more like a technique, but in DMAC, you have to have a coordination. You have to feel the graft. You have to feel your antechamber, you have to feel the pressure that you are applying. So that's why the learning curve is quite steep in DMAC. You need to practice a lot before directly shifting onto the patient for doing DMAC. Graft manipulation, post-operative detachment, endothelial cell loss, and all these are, yes, issues with DMAC when you are, especially when you are shifting from DSEC to DMAC. Donor age, again, DSEC you can take young donors like 10 year, 15 year with good endothelial count. For DMAC, that's a problem. If you take such young donor, then it will be very difficult to attach the graft. Media has difficult situation. This is probably the most important factor where you have to do a DSEC. If the media is hazy or there are difficulties like defective iris, vitreous in antechamber, aphakic patient, vitrectomized patient, in all these patients you have a tendency to go for DSEC rather than DMAC. So I'll just show few of the cases that I have performed DSEC where I could have done DMAC, but I deliberately opted for DSEC. This was a case of a posterior chamber IOL in antechamber leading to pseudophakic corneal edema. The IOL was huge and the haptics were deliberately tucked in the angle. So it required me to expand the IOL and then cut the IOL into two parts where it was stuck, then to release the adhesion from the angle. So when somebody does this, there is a lot of manipulation. The DSEC steps are similar to a routine DSEC, so I am not going to discuss about that. But this is the technique I prefer, corneoscleral tunnel with a Bushin glide. So I had to cut the IOL and I have to release the adhesion from the angle, and when I brought it out you could see there are vitreous stacks. So when you are operating in such a patient where there is vitreous loss, the iris is released, there will be a lot of fibrin formation. Unrolling the graft and getting it attached to the cornea may be a tough task. So in such patients it may be a good idea to go for DSEC rather than DMAC. So next video is, this is just to show you, if you have a microkeratome, and the recent study suggests if you can do ultra thin DSEC, the visual quality may be almost near what you get in DMAC. So again, if you have a microkeratome, then you can go for DSEC in patients where you feel there will be difficulty. As you can see in this patient had undergone ICC. It was a 99-year-old female. We had only one chance to operate on her. Right, so we didn't want to take any chance. She had advanced glaucoma, all complications were there. Our goal was to just give her some corneal clarity so that she gets some ambulatory vision. So in such patients, performing DMAC will be very difficult. There is a lot of scarring in the deeper layers. The antechamber is not regular. Iris, you could see it's defective superiorly. So in patients like this, you can go for DSEC. Here I am putting a stay suture because I was little bit worried after injecting the graft it may fall behind. So that's why I put in 10 nylon, and once the graft was inside and it is well attached, you can take it out. The beauty of DSEC is once you have injected even a half-filled air bubble and your graft is just behind your cornea, then all the difficulties are gone. You can easily ensure that the graft is attached. With DMEC, you are not sure. If the graft is reverse oriented and the patient is having a huge iris defect, then that is probably a scary thing to operate. So this was a case of xeroderma pigmentosa with ocular surface problem with a failed graft. Here again the option was to not to go for PKP because of the surface associated issues, and there was 360 adhesion as well as adhesion at the graft host junction. So when you are operating such cases, DMEC is next to impossible, or you have to take a very small graft. The earlier graft was 8 mm, so we went out with a DSEC with 7.5 mm graft, and the pre-op OCT clearly suggested the posterior graft host junction was a step pattern. It was not a planar kind of junction. So if you do a DMEC, here you can see the DSEC graft can be stroked and brought into the center, but it's not that easy for a DMEC graft. Once there is a posterior step, as you can see here in the microscope OCT, there was already a posterior step. If the graft would have gone beyond this, it would have been really impossible to bring that DMEC tissue to the center. And you can see I am highlighting here, there are 360 degree synechia. I didn't want to release that. That would have created a lot of inflammation and would have increased the chances of graft rejection. So this is the last case I'd like to highlight here. In cases with CHED, or even nowadays people are doing DSEC in cases of ophthalmos where there is a significant corneal hedge, that performing DMEC is next to impossible. So in these patients, it's better to go for DSEC. Why? Because once your graft is in and you inject air bubble, then you can appreciate the classic ring of DSEC graft, and that will tell you where your graft exactly is. And after you inject the air bubble and fill the interchamber, you can see the graft edge is visible to me. Even if the center part I am not, I don't know where where my graft is, but I can see a nicely 360 degree rim of 2 rings. That tells me that yes, my graft is well attached. So these are the few cases just I showed you. So when you are dealing with cases with complicated interchamber situation, the visibility is not good, patient is aphakic, and you don't have a choice to go back to OR again and again, or the patient is having glaucoma implant, operated trap with large iris defect, hypotenuse patient, or for medical, social or some reasons, maybe the health problems with the patient, you have only one chance. You cannot operate again and again in that patient. In all these cases, go for a more predictable surgery like DSEC rather than DMEC. With this, I'll conclude here. Thank you very much for the attention.
Thank you, Praful. It is a nice video demonstration of all the reasons to go for DSEC or DSAEK in these cases. So we have time, and because we can wait for the other 3 speakers. So you have any question? We can take question for any of the talk.
Sir, I have a question for you. What is your selection criteria? Which are the situations where you would go for DSEC instead of DMEC?
No, that's what I am trying to convey people. DMEC terminology actually just in recent years, last maybe 5-6 years, it's so glamorous terminology. People are actually, all corneal surgeons are thinking DMEC as a way to go. It is not like that, because if you see the recent data of 10 years published data now coming off about the DMEC, DSEC is going good over last 20 years, and you know the results are quite, you know your own results also in your hand. So DMEC is definitely one step ahead because of very quick rehabilitation of this. That is the only advantage I find. And it is just like a game changer in those patients who has Fuchs dystrophy. Fuchs dystrophy is the only indication where you can play with DMEC and you can give actually superb result, much better than DSEC or DSEC. But in PBK cases, where in India we get most of the patients, and not only these are simple PBK, these are more of complicated PBK. So you need to do lot of manipulation. Where your mental clarity should be good, that no, I will go for DSEC in this case because I can do better job, that because the donor manipulation will be much higher in DMEC in this case. So DSEC, as you said rightly, that it is the least donor manipulation from both from donor preparation point of view and also from the donor unfolding point of view. Two places where the endothelial cell loss happen. In the donor preparation, people have shown that it is cell loss between 5 to 18%. So if you are during donor peeling only, you are losing 18%, and during unfolding another 20% you will lose. So when you are actually just on first post op day, you are already 40% out. So it is not that. So my suggestion is, wherever you are comfortable, you do that. In spite of best affordable tissue, in spite of 80% of US, the demography says that their main primary indication is Fuchs dystrophy. Over a period of last 10 years, you know that only 50% of US surgeons are doing DMEC. And there are now hybrid because of almost giving almost 99% same results as DMEC. So people are going to nano thin or ultra thin DSEC. So these are alternatives, and the mechanism, the peeling, donor graft. So I don't think that is DMEC is much superior. That this, I have done a lot of DMEC. I am obsessed, so to say, about it. But I feel over a period of 8 years, sometimes I feel why I didn't do DSEC in those cases. Thank you.
Thank you, sir. That means a lot to me as well as all the corneal surgeon. So, any questions from audience?
This is for Dr. Mal. When we look at atypical organisms, the practice makes perfect. No? Even seeing a young novice seeing smears is picking up of even simple organisms is going to take time, and it improves over time definitely. How do you solve this problem of trying to get uniform or higher sensitivity and specificity rates in terms of picking up from smears?
Okay, so that's a difficult one, because I think in medical colleges that's not happening, that they actually go and see the slides, but it should start from there. And if the residents make efforts to go to the microbiology lab and see the slides, I think that would help a lot. Most of the fellowship programs in Cornea, they do train the fellows to actually see slides, so that's where you can take it up. And then in your own practice, if you have a light microscope and you do a grams, you don't have to have calcoflow white. We have shown that trypan blue can also be used to identify fungus and acanthamoeba cysts, so that's something else that you can do. And gram staining is actually fairly simple to do.
Yeah.
So as you keep on seeing, and if you have a high index of suspicion, I think that would definitely improve the sensitivity of picking up organisms on slides, the sense spec. But it starts from the training.
Yes. So I am telling my experience when because we had a tie-up with microbiology lab. So when they used to say that this is this organism, this is that organism, I used to take their crude plate, I smear it, try to find out our own way, that is, what is the true picture of this, because then you might have a very good atlas is there, you keep your atlas, and then I tried to, that I am talking about 30 years ago. So that is the way I have learned. Still I encourage my fellows that you just see whenever our microbiology department is giving report, that is fine, but you go and take a sample from that plate and ask them to do gram stain or KOH, whatever. Now see what is actually. If you see 50 of them, then it will imprint your head. Same as you are telling in the medical college, the same line of teaching.
The only issue in the medical colleges is that you have, ocular specimens are so small, very less amount of samples. So that's where the difficulty arises in the microbiologist per se being able to identify.
Yes.
Because I've had that experience myself when I was working in Apollo, and the microbiologist had never seen nocardia, so I showed it to him. He had not seen microsporidia, so I showed that to him. But I think it's important for us to be able to, I mean, when we are, teaching the residents, we should encourage them to go and see residents and fellows. I think it's important. And I think there should be efforts made to also conduct some kind of, digital education. And Dr. Savitri from LBPO is actually trying to work on that, where you have these online courses where people can join. And there are always meetings like Bugbusters where we have, a lot of this kind of work going on, and we actually demonstrate, and we have wet labs where we can, teach people.
Thank you.
Any more questions?
So from the dry eye perspective, let me ask you a question also, that we can just discuss some of
Yeah, just we can discuss because we have time at least.
So the
9
preoperative
minutes.
workup,
No,
so
19
both in cataract patients and in LASIK patients. So what do you recommend? Because we do see a lot of cataract patients, and nobody actually kind of does a detailed workup of these patients. So what would you recommend for practicing ophthalmologists? What should be the things that they should be looking for? Certain cues, clues, whatever it is.
So for LASIK, the workup is pretty defined. So we do a Shermer's 1, 2, we do a TF but and T-but levels. These are the two screening tests, and definitely any staining is obvious. That is part of your clinical examination. What happens in cataract patients is that at that age group of 40 plus, 50 plus, most of the time there is a lot of coexistent meibomitis which is undiagnosed. And you will see it actually by the first post-op week itself, the putting of so many medication. Like we still have putting individualized, we don't do combination. So you have 6 times of antibiotic, 6 times of steroid, and an NSAID to boot. So this really worsens the meibomitis. By the first post-op day, the patient has significant meibomian problem. So in terms of evaluation, I would say just as part of we check RHO+ and RHO+ negative, at the same time just press them a couple of meibomian orifices. So they don't actually, it is not yet evident till you press that there is very little secretion that is coming out. So that will give you a clue that many of the glands are blocked. And these are the cases which will actually worsen post-op. So all these patients, so my routine is I check RHO+, press a couple of glands. If it is there, then I'll tell them you don't take a date till 15 days or 1 week after. So I start them on doxy preoperatively itself. So in these patients continue doxy for a month of post-op from about 1 week pre-op. And this way I see that most of the times there is a good resolution and favorable outcome compared to, I rarely have to use, now I know in private practice a lot of practitioners apart from the antibiotic and the steroid and the NSAID are also giving one more molecule of lubricant, and that really decreases compliance. So I look at adding a lubricant only at the 6th week, the glass appointment rather. And by adding doxy preoperatively itself, the need for adding a lubricant at the end of 4 or 5 weeks is also very, very minimal for me.
So is there any role, so this is for people in the audience also who have access to certain investigative modalities like LipiView. How many of you would actually do a LipiView for some of these cataract surgery patients pre-operative? Okay,
so actually for mostly, because it is again, I am recently obsessed with LipiView because it gives so much beautiful picture, and you pick up so many things within 10-15 minutes which we may miss clinically. So if you see that recent data suggests that 4 hours you said that smartphone user or any digital device, we all uses more than 4 hours. So that is the one of the reason, and I have series of photograph, probably I will come up sometimes to try to analyze those data. And if you see that for the, what you have said, absolutely perfect, that 40% in our population over the age of 40, they are having MGD at any form, any level of MGD. So cataract operation, especially with premium IOL operation, your biometry may be wrong if you try one and give treatment for 3 months, then you schedule for operation. In some of the patient, you will see that toricity, the astigmatism power is, the axis is different. All these things we have seen, we have captured those data, and these patients similarly with premium IOL where you are giving trifocal or EDOF kind of, or any multifocal IOLs. Those are very important point. So MGD is with us for every age of population. We have a series of huge data on pediatric MGD. So the reason being the same, COVID has probably increased that prevalence of those data. So it is better to do either clinically, or if you have some imaging system that you can explain it better to the patient, because it is, you can show it is wrong with your glands. So you treat them, delay the surgery for 6 weeks to 12 weeks, and they go ahead with cataract. Similarly with LASIK, we have a, in our protocol, in our dry eye workup, LASIK workup, LipiView is there. We have also IDRA is there. So either of them said that we gave a complete report of, and all these kind people are tech people. They are working for 8, 10, 12 hours in digital devices. And again, there is a huge population where you will see that 40% of the glands drop out areas are there. So they will complain definitely. They will not drop their job. They will continue their job, but the blame will come on you that you have done the LASIK surgery and they are doing worse and worse. So that is my take as of now, but it is required, I mean.
Yeah, so I think part of it, what you mentioned, was the preoperative counseling as well, how important that is, particularly for refractive surgery patients, to tell them that, okay, if you have it prior to surgery and you question them about the symptoms, then I think that the counseling about it aggravating post-surgery is very important, because for 6 months down the line, they will be okay thinking that the nerve function is going to come back, but if they have underlying MGD which is overlooked and not treated, then those symptoms persist for much longer. So they have a lot of difficulties. A lot of them will complain of difficulty in opening their eyes in the morning because the eyes become so dry at night. And that's
Yes. And so far also, that is also true for contact lens first time user. You need to, because you are inducing another agent for dry eye. They are all habitual digital device user for 8 to 12 hours. You are adding a contact lens, and that will be for 12 hours. So whole milieu of the ocular surface is getting disturbed by any means. So ultimate blame will come to you unless you counsel them properly. This is your problem. We have done this only, and you have to maintain certain lifestyle changes, whatever kind of thing you have to tell them, and then proceed.
Another thing of contact lenses, even though you advise daily disposable, but sometimes it may not be the cost effective. So even the patients who want monthly, I tell them actually use your continuous wear, but don't use it as a continuous wear, because those are fluorosilicates which have much higher oxygen permeability.
Yes.
So they will never stick to your guideline of 10 hours or 12 hours a day. So use the 24/1 as a daily wear. So you're not using overnight, but at the same time you're benefiting from the material and better oxygen permeability. So even if they extend to 12 to 16 hours, it's not an issue. They can clean it with like a routine. It's not a continuous wear.
Yeah, I think the contact lens wearers who come to you for LASIK surgery also have to be counseled.
Double trouble.
Yeah, so
Double
they
trouble.
also have a lot of problems post-op.
So post-operative dry eye, one thing we have not mentioned, that is after penetrating keratoplasty or after DALC. These are group of patients, because we are cutting all the nerves. So unlike your endothelial keratoplasty, that way is very safe from dry eye point of view. But these are young patients, and their regeneration of nerves takes longer time, and a lot of other surface problem is there. So we should also, we have made our protocol, this group of patients should get a tear substitute at least 3 to 6 times depending upon their ocular surface status. Any other question? No questions?
10 more minutes.
another 10 minutes are there in our hand. So any question for anybody about any, yeah. Acha, she is also leaving us. Onu is also leaving us. So we can have you, if you have any question, because we are here, we can take up any other questions if you want to. No question?
So, this is the netrasudil and the ripasudil, which are supposed to help corneal endothelial migration. So, how effective is it if you want to give it as an adjuvant therapy to a severe striate keratopathy postoperatively?
This is still a debatable subject from endothelial point. I am not talking about glaucoma point of view, I am talking about endothelial. So because if you see the original data from abroad, and originally Glenatech from Japan was available. I have a opportunity to use it. It works, but in some of the cases, not every cases. Recently there is a publication by Kinoshita group. There is a concept of mature endothelial cell concept. Have you heard of it?
No.
The concept of mature endothelial cells. It does not depend on age. The peripheral, they have studied that endothelial cell culture, and ultimately that is one of the treatment of future kind of endothelial dysfunction. They have published their data, and their 5 years follow-up data recently published. And they have taken the peripheral cells of the PK graft and they cultured it. From there they identified some biomarkers also. So they are telling, they are also, Singapore group is working on that, not what we think that a 45 years old gentleman's endothelium 2500, say 160-year gentleman's 2500. These two 2500s are not same.
Yes.
Because of mature endothelial cells are different in two groups. It is not that the young one has a more matured cell or older one. It is totally irrespective of age.
Okay.
And that's why during our keratoplasty and even any kind of keratoplasty, we see we have done beautiful surgery, you pat your back, that done nicely. Then 1 year down the line, endothelial cell from 2500 to 800 without any reason.
Okay.
No reaction, nothing, patient is following up. All of us have this experience, and you try to understand why this is happening. They are telling that probably the mature endothelial cells are less in that group. Whereas in another group of patients, we see there is much more manipulation. Still your endothelial cell count is going good for 3, 4, 5 years.
Okay.
They are the mature. So ROCK inhibitor, or either neparsidil or ripasudil, whatever,
Yes.
they are actually working on this mature endothelium. We do not have any idea how we can identify those, but they are working before the graft. They will, like we trypan blue, we stain the endothelium. Similarly, they will stain with some biomarker, and that will tell that what is the percentage of mature cell in that particular donor cornea. And probably those days are not to, I mean, maybe within 10 years it will come.
Okay.
So probably that is why the ripasudil, our experience during the COVID time, because that time tissue was not available, early striate keratopathy, early bullous keratopathy, peripherically clear, or early endothelial cell periphery clear, central edema. We have tried in many patients, no significant difference from our own ripasudil.
Yes.
I have only used in 5 patients the Glenatech, and in 3 of them it worked, 3 of them.
So there was a difference between the
No, original, that is
The
the
original
original one
molecule and-
molecule. They have a number, no? They have a number. Even the Kinoshita group worked with the ROCK inhibitor. Recently they have got patent, but it is a number. There is no, I mean, here ROCK inhibitor, there ROCK inhibitor, probably there is different. That's why we see so much complication of netarsudil in our.
So that has been the
That
early
is not
experience.
reported in US. US netarsudil, they are not reported such huge number of epithelial, corneal
Honeycomb.
epithelial, honeycomb type of. It is not reported. Probably they are not the same molecule. There are a group of this ROCK inhibitor.
Yes.
We do not know actually what, how they are. It is just like hypersol 6. Similarly,
It was
we are
hypersol
using
6 only
hypersol.
stings, but this is causing honeycomb.
Honeycomb.
This has been
This
the early
is,
experience.
I am not using it unless I am convinced.
Okay.
So I am not using it, but people are using, company are getting
So
out
whatever
of it.
reason why when we start it is either for the striate keratopathy or there is a pre-existing glaucoma. So you are adding along with this for
Pre-existing
prolonged
glaucoma,
steroid.
yes, the glaucoma people are telling it is working in some of the cases. Again, probably the trabecular mesh works some
Yeah.
But the
kind of.
incidence of honeycomb is much worse when there is a existing striate keratopathy or a compromised cornea.
So
It
that's
is
what-
less compared in a clear cornea
Yeah.
and a nice
In,
cornea.
yes,
So
yes.
that's because of compromised endothelial function, right? So you
I
don't
thought
have enough
we
cells
are
to
trying to
migrate.
help the endothelium by better migration. But
But
it is
probably
actually
we don't
worsening
have
it.
enough cells that will migrate, and that's the. Yeah,
That is, probably that is the reason.
I think we can end the session.
So, thank you very much.
Thank you so much for being here.
And we will end the session. Very good discussion. Thank you.